Marvel. Bro, I have this absolute wild medical mystery for you. Picture this. I have this absolute wild medical mystery for you. Picture this, a 76-year-old grandpa pulling up to the ER. He has multi-infarct dementia, a sketchy heart rhythm called chronic AFib, and high blood pressure. But he is actually there because he has a cough and a low-grade fever. Arthur, sounds like typical grandpa core Marvel. What else? Marvel. Get this, he has been treated for pneumonia twice in the last year. And for the past 6 months, his throat has been glitching. He has massive trouble swallowing, and he randomly regurgitates totally undigested food. Like, his body is just hitting Control Z on lunch. Arthur, that is rancid. Please tell me it gets weirder. Marvel. Oh, it does. On the physical exam, his breath smells absolutely foul, like biological warfare. And when you touch the left side of his neck, there is this weird, squishy, fluctuant mass just chilling there. Plus, the doc hears crackles in his right lung, and the chest x-ray shows an infiltrate. Basically, he is aspirating that old food straight into his lungs. They start him on antibiotics, and he gets way better. So, Arthur, what is the play? How do we diagnose this man? Is it A. Bronchoscopy, B. Contrast esophagography, C. Gastric feeding tube placement, D. Neck mass biopsy, E. Upper gastrointestinal endoscopy, Arthur? Okay, wait. A squishy neck mass and pocketing undigested food from 3 business days ago? That is definitely B. Contrast esophagography. He has a Zenker Diverticulum, bro. Marvel. Spot on, Arthur. B is the correct answer. The crowd goes wild. Tell the people how you knew. Arthur, it is the ultimate throat glitch, man. A Zenker Diverticulum is a fake pouch, a pseudo-diverticulum, that forms in the back of the throat. Basically, the upper esophageal sphincter, specifically the cricopharyngeus muscle, forgets how to relax. It gets all tense, the pressure inside the throat spikes, and the lining herniates outward through a weak spot like a balloon. Marvel, a literal food pocket. Imagine hoarding a snack in your neck for later. No wonder his breath smelled like a garbage disposal. Arthur, exactly. That is the halitosis. The food just sits in the pouch, rots, and then hours later, it comes back up totally undigested. And since his brain is dealing with dementia, he accidentally inhales that rotting buffet into his lungs, which explains the recurrent aspiration pneumonia. Marvel, why not just do an upper endoscopy though? Option E. Just go down there with a camera and film it for TikTok? Arthur, bro, absolutely not. That is a massive trap. If you shove a rigid camera scope down his throat blindly, you could easily slide right into that fragile pouch instead of the main esophagus and pop it like a balloon. Perforation city. Not a vibe. Plus, a small pouch can be easily missed on camera. Marvel, fair. What about option D, poking the neck mass with a biopsy needle? Arthur, dude, if you stab that neck mass with a needle thinking it is cancer, you are literally stabbing a pocket of old food and tearing his esophagus open. It is squishy and fluctuant because it is a pouch of liquids and solids, not a solid tumor. Marvel, what about a broncho whatever? Option A. Arthur, bronchoscopy is for looking inside the lungs if a tumor is blocking the airway and causing pneumonia in the exact same spot. But even then, you would do a chest CT first. And option C, a feeding tube, is just quitting before you even try. If you fix the pouch with surgery, he can eat normally again. Marvel. So the contrast swallow study is the undisputed GOAT here. Arthur, exactly. He drinks a radiopaque solution. You take serial x-rays, and you literally watch the contrast pool inside the neck pouch. It shows you the exact size and if it is spilling into his lungs. Then the surgeon goes in, cuts that tight cricopharyngeal muscle, fixes the pouch, and Grandpa is back in business. The breakdown symptoms and signs listed: progressive dysphagia, difficulty swallowing, regurgitation of undigested food hours after eating, halitosis, foul-smelling breath from rotting food, fluctuant, squishy left neck mass, fever, crackles, and right lower lobe lung infiltrate, signs of aspiration pneumonia. The best giveaway clue, the absolute goldmine clue, is regurgitation of undigested food paired with a fluctuant neck mass and foul breath. Whenever an elderly patient is spitting up intact food they ate hours ago and has terrible breath, your brain should immediately yell Zenker. The trickery Exam traps. The examiners try to bait you into choosing an upper endoscopy, choice E, or a neck mass biopsy, choice D. They want you to think a neck mass always equals cancer, biopsy, or that dysphagia always gets a scope, endoscopy. Doing either of these on a Zenker diverticulum runs a massive risk of iatrogenic esophageal perforation, literally tearing the throat open. High-yield exam lecture Zenker diverticulum is a pharyngoesophageal false diverticulum, meaning it involves only the mucosa and submucosa, not the full muscular wall. It occurs in the posterior hypopharynx, specifically through a weakness in the muscular wall known as Killian's triangle, located just above the cricopharyngeus muscle. The underlying pathology is impaired relaxation and spasm of the cricopharyngeus muscle during swallowing. This failure to relax leads to increased intraluminal pressure, forcing the mucosa to herniate posteriorly. It is most commonly seen in males over the age of 60. Key clinical features include progressive dysphagia, halitosis, gurgling sounds in the neck, and regurgitation of undigested food. Affiltration of this retained material into the respiratory tract leads to recurrent aspiration pneumonia. Diagnostic and management algorithm: initial and gold standard diagnostic test. Contrast esophagography, barium swallow study. This safely visualizes the size and location of the pouch without risking perforation. Contraindicated procedures: avoid blind upper endoscopy and fine needle aspiration/biopsy of the neck mass due to high risk of esophageal perforation. Definitive treatment: surgical intervention consisting of a cricopharyngeal myotomy, cutting the tight muscle to relieve pressure, often combined with a diverticulectomy, removing the pouch, or endoscopic stapling.